So today we are going to be discussing the glaucoma medications. So it's a huge topic. We have many medications we have to talk about, but we have to make it short within 1 hour. So this presentation is going to be free of any financial interest that I have to disclose. So the fact we currently have multiple surgical options to control the glaucoma is a great boon and great blessing, actually. However, we are also nowadays so blessed to have a wide variety of medications that works in different pathways. So can you just imagine what was the situation 70 years back or maybe less? So this is a great blessing we have to thank God about. So let's talk a little bit about history. So let's go back in the 19th centuries. Actually, in the late 19th centuries, where the physicians who worked under the French professor who is Albrecht von Graffet, who developed some medications that work on the intraocular pressure. And at the same time, or at the same period, the French professor Ludwig Lacquer developed the physostigmine, which is an extract of calabar bean. Almost at the same time, pilocarpine come to the surface, which is an extract of jaborandi, developed by the Adolf Weber, the German professor. So despite these medications works well on the intraocular pressure, but did not treat the underlying cause, which is glaucoma. But it remained the mainstay for treatment for glaucoma for the next 75 years. Until the era of the 1950s, where the oral acetazolamide and topical epinephrine developed. And can you just believe that these medications did not, or is not popular nowadays to be used as glaucoma medications. And then after like 20 years, maybe, the beta blockers introduced to the market and approved subsequently by the other medications that control medications up to now. This is the timeline of these medications from the beginning up to now. And 3 or maybe 4 of these medications just developed in the last 4 years. So let's start about talking about the parasympathomimitic. This class of medications is mimicking the action of acetylcholine. It was considered the first class of agents to treat glaucoma in the 19th centuries. And it was popular until we faced lots of side effects that was affecting the eye and systemic problems. One of them is the pilocarpine, which is an extract of jaborandi, as I mentioned, which is an American shrub from the genus Pilocarpus myrophilus. It was used as a treatment of some types of glaucoma for hundreds of years. Initially started to be treating the primary angle closure glaucoma in addition to open angle glaucoma and plateau iris as well. And it has many preparations and concentrations. And also it comes as a combination between the pilocarpine and timolol. It comes with a gel preparation as well. And also on oral preparations to treat the dry mouth and Sjogren's syndrome. And recently, it was approved by FDA to treat presbyopia with a special concentration. So the mechanism of action to treat glaucoma is by decreasing or reducing the aqueous humor outflow by contracting the ciliary muscles. It has like a minimal action on the aqueous humor formation and iris-clear venous pressure. So in angle closure glaucoma, it stimulates the cholinergic receptors, which is found in iris sphincter pupil, which induce meiosis, which can help to relieve the pupillary block and then open the angle and change the anatomy of the peripheral iris. So by contracting the ciliary muscle, it enhances the conventional outflow. So in open-angle glaucoma, when the ciliary body relaxes, the Schlemm canal and outflow system is not working well. But when it contracts, the ciliary muscle contracts, the Schlemm canal and the outflow system open, and this can reduce the intraocular pressure by enhancing the outflow. So just to repeat these things, so the contraction of the muscle, just helping the unfolding of the trabecular meshwork, and then widening of the Schlemm canal. This is helpful to facilitate the aqueous outflow from the anterior chamber through the trabecular meshwork, through the venous collector channels, and then to the venous circulations. And then with age, the pilocarpine efficacy decreases with age because the accommodation, as you know, the accommodation with age is limited. And some reports mention that the uvuscleral outflow is affected by the pilocarpine because this is an opposite mechanism of action of prostaglandins. But is this really a realistic thing or just theoretical? Because we know that the prostaglandin is working on the uvuscleral outflow, while the pilocarpine is blocking this method of outflow. I think this is just theoretical because at the real world, the pilocarpine is additive to the pilocarpine, and prostaglandin in general is additive to the pilocarpine when we measure the pressure after putting the drops all together. So the end result is to decrease the pressure if we put these two medications together. Pilocarpine in general is contraindicated in some inflammatory eye diseases like uveitis or neovascular glaucoma because it's break down the blood aqueous barrier. And it is also contraindicated in phacoemorphic glaucoma because of the displacement of the iris lens diaphragm, and also contraindicated in aqueous misdirection. It is contraindicated in some, or relatively contraindicated in some diseases like breathing problems, gallbladder diseases, kidney and retinal diseases, heart diseases. It has ocular side effects. Some of them is very popular and well known, and some of them is very rare. So ciliary muscle spasm and brow ache is well known to have, or to be with pilocarpine, myopia and dim vision with constricting visual fields, cataract formation with long-term use of pilocarpine, retinal detachment can happen in some cases, and allograft rejection because of the inflammatory process that can be induced by pilocarpine, and conjunctival hyperemia because of the vasodilation and some preservatives that's contained in these preparations. Eicothiophyllate iodide is one of these preparations, which is more potent, much potent than pilocarpine. It has a maximum effect up to 2 weeks, and with a maximum effect within 24 hours. It has intense and prolonged meiosis, and it can cause anterior subcapsular cataracts. If we plan to go for general anesthesia, it's better to stop the eicothiophyllate iodide 6 weeks before if the general anesthesia is going to be with succinylcholine. Actually, eicothiophyllate is not popular anymore to use as glaucoma medications. So let's move to the beta blockers. Beta blockers is firstly demonstrated for oral administration back in the 1966-67. Propranolol is not suitable for ocular use because of the toxicity to the cornea, and till the development of timolol, which is introduced to the market in 1978. Timolol is one of the most glaucoma medications that has been studied and was used as a reference comparing to other medications. and it was used by many companies for glaucoma treatments. And by the arrival for prostaglandins, it's declined to be used anymore as usual. So the standard dosing is twice daily, and it can be used as every morning because it has long washout period. But the other medications can be used as twice daily. Because of the less effective during nighttime, it is better to be used in the morning. And it has the beta blockers in general has many preparations. And you can see here the timolol itself is the most popular medication that's been used, and the more medications that is studied on the past. And it comes with a lot of preparations, either preservative-free or combined with other medications, like in this table, which is can be combined with other categories of glaucoma medications. And betaxolol has a neuroprotective property, which has a calcium channel blocking activity. And the adrenoreceptors in general, if we can study this category, it has alpha-1 and alpha-2 subtypes. And the beta adrenoreceptors has beta-1 and 2 and 3. The most popular is 1 and 2, while 3 is more known in mammals. So beta-1 is more abundant in cardiac, and the beta-2 is more abundant in the pulmonary, vascular system, and uterus. So timolol and other medications is inhibiting both beta-1 and 2. That's why it's non-selective, while the betaxolol is high bonding affinity to the beta-1 adrenoreceptors, which is available in the vascular system and the pulmonary system. I'm sorry, it is more abundant in cardiac system. So the mechanism of action of the beta blockers in general is not well known or elucidated. So the IV reduction is achieved via suppressing the aqueous humor production, like in the ciliary, where the interaction or can be interacted with the beta-2 receptors, like in the ciliary epithelium or ciliary arteries. Some theories reported that it can inhibit cyclic amino monophosphate production in the ciliary body, and some reports mentioning that there is an endogenous adrenergic tone controlling the aqueous production, which is mediated by epinephrine. So beta blockers can interfere with this. So timolol in general can lower the intraocular pressure within 2 weeks of initiating of the medications. And the amount of dropping of intraocular pressure is between 19 and 29. So timolol was the most effective IOP lowering agent, of course, after prostaglandins. And it is more potent than betaxolol, and it has the same efficacy as other agents in the beta blockers class. It has a local side effects like punctate keratopathy, dry eyes, and allergic reactions. And it is, as you know, it is contraindicated in diseases like COPD or asthma, while betaxolol is more favorable in this disease. In cardiac conducting defects is contraindicated, and betaxolol has a fewer effects comparing to timolol in this disease. Other systemic side effects including depression and fatigue, anxiety, confusion, and sexual dysfunction, impaired neuromuscular transmission. And it has to be used with caution in pregnant and nursing ladies because it has effect on the fetal status, can cause bradycardia and cardiac arrhythmias. And it is more tolerable if it's combined with other agents. So it is more, tolerable if you use Cozopt comparing to timolol, and if we use Combigan comparing to Alphagan, and Ganforte comparing to Lumigan. So this is for unknown reason, but it is well known to the patients and to the doctors. Other categories, which is carbonic anhydrase inhibitors. The carbonic anhydrase enzyme, it catalyzes the hydration and dehydration of the carbon dioxide. It is available in most of the organ of the body and in the eye as well. So it has many isozymes or isoenzymes, and one of them is in the non-pigmented ciliary epithelium, which is blocked by this category of glaucoma medications. So the carbonic anhydrase is one of the enzymes that can be helpful in aqueous humor formation. Inhibition of this particular enzyme can lead to lower intraocular pressure. This class of medications has systemic and topical preparations. It was, mentioned at the beginning by the Richard Robin, and the effect of on the IOP lowering is discovered by Bernard Becker in the 50s in the last century. As we mentioned, it has a systemic and topical preparations starting from acetazolamide, metazolamide, and diclofenamide, which is systemic preparations. Some of them can be used intravenously, while brinzolamide and dorzolamide is the ocular medications. So acetazolamide, which is known as Diamox, metazolamide, neptazane, which is rarely available here in our region. Dichlorphenamide is known as Daranide, is not popular to be used as glaucoma medications nowadays. So let's start by dorzolamide, which is first introduced to the market in 1995. It has an acidic media to be used, so that's why it can be causing ocular pain and stinging and discomfort at the beginning. While brinzolamide, it has an basic media, that's why it is more tolerable comparing to dorzolamide. It is suspension preparation, and because it is dissolved in a viscous suspension, and it has a high lipophilic media. This is a table comparing dorzolamide to brinzolamide. And the mechanism of action, as we mentioned, it can inhibit the aqueous humor secretion by blocking the carbonic anhydrase enzyme in the non-pigmented ciliary epithelium. So the mechanism of action of acetazolamide, particularly, it can decrease the aqueous humor formation by at least 30%, the maximum effects after 2 hours, and it can be washed out up to 3 days. The affinity of topical carbonic anhydrase inhibitors to the carbonic anhydrase isoenzymes is more of the carbonic anhydrase isoenzyme number 2, while the acetazolamide has a dual affinity to carbonic anhydrase number 2 and number 4. That's why it's having a potent efficacy comparing to topical efficacy. So is there any additive effect of carbonic anhydrase if we combine the topical and systemic? So the answer is no. If we use the systemic medications, it's not, or there is no point to give topical medications with the same class. So it's contraindicated in some patients, like in people with sulfa allergy, or having a renal impairment or hepatic impairment. Of course, it is contraindicated in pregnancy, especially at the beginning, and with the premature newborn. So don't give these medications to premature infants, because it can be harmful. Ocular side effects include choroidal detachment and transient myopia, marginal keratitis, and it has been reported to affect the corneal endothelium in some cases, and in sick endothelium, like in Fuchs dystrophy or complicated cataract surgeries, that can induce hydration and thickening of the cornea. and the end result is going to be, of course, corneal decompensation. So this is especially with dorzolamide comparing to brinzolamide. This is a report that is mentioning that dorzolamide, which can affect the corneal endothelium irreversibly, and it has the systemic side effects of carbonic anhydrase, like in blood dyscrasia, and it has a bitter taste in both, and gastrointestinal upset, especially in systemic, paresthesia and numbness, especially in acetazolamide, renal stone formation as well, and systemic medications, and acidosis. Of course, as I mentioned, it is not advocated to be used in immature newborns. Alpha adrenergic class. The alpha adrenergic in general has many subtypes, alpha 1 and 2, and imidazole. Let's start with epinephrine. Epinephrine has alpha and beta adrenergic agonists. It was first topical adrenergic agent being used to lower intraocular pressure and open-angle glaucoma. It increases the outflow. One of the side effects is can cause mydriasis and conjunctival vasoconstrictions. It is not suggested or recommended to be used in blepharoptosis because can cause miscorrection of the eyelids surgeries. It's not recommended as well to be used in retropalpal anesthesia because can cause central retinal artery and tachyarrhythmias. And both epinephrine and dibephrine is not recommended to be used in narrow angle glaucoma because it can induce pupillary block and cystoid macular edema in aphakia and in complicated cataract surgeries. And the adrenochrome deposits is well-known complication or side effects of epinephrine and dibephrine. Clonidine is one category is the first alpha agonist used in systemically and topically for glaucoma back in the 1960s. First was used as nasal decongestant, and it has a very narrow therapeutic index, and because of the serious side effects that we'll mention in a minute. So as we mentioned, the most serious side effects of clonidine is symptomatic hypotension and syncope and sedation. That's why it's not popular anymore to be used. It is the parent of the apraclonidine and the brimonidine. And the apraclonidine, it has hydrophilic, it is hydrophilic property, and it has a low penetration to the cornea, and also that's why it is has low blood-brain barrier penetration. That's why it is centrally. There is no central mediated side effects comparing to other medications like brimonidine or clonidine. It is indicated in some procedures like laser procedures, and it is good alternative in children because of the least side effects comparing to these medications. It can reduce the pressure by reducing the aqueous pressure or the aqueous production and improve the trabecular outflow, reducing the episcleral venous pressure. The brimonidine per se has high selective alpha-2 agonist comparing to clonidine and comparing to other medications like apraclonidine. It reduces the aqueous flow and increases uvoscleral flow. And if we talk about the lipophilicity, the most lipophilic agent is clonidine. That's why it's penetrating the blood-brain barrier more than brimonidine. And the brimonidine has more lipophilic property comparing the apraclonidine. So apraclonidine is the more benign agent to be used and the least side effects. And the unilateral applications of both agents has efficacy to the other eye to reduce the intraocular pressure, which we call it the crossover effect. Some of the side effects of the primordial is sedation, hypotension, and centrally mediated effects like CNS depression. And in long-term use, it can induce severe follicular reaction. It is contraindications in children in general because of the CNS depression, and also contraindicated in cardio and cerebrovascular diseases and hepatic renal impairment and Raynaud's phenomena and diabetic eye diseases and anterior segment ischemic syndrome as well. So let's talk about the prostaglandins. There is no doubt that prostaglandins analog have tremendously enriched our medications, especially in the last 20 years. So prostaglandin derivatives introduced in the medical armamentarium in the 1969, in the 1996, with the available of the latanoprost. So it reduced by far the surgical intervention compared to the era before the prostaglandins. Why it is more convenient? Because it is potent compared to other agents, and it achieved the intraocular pressure target. That's why it reduced the intervention with time. It is more convenient because it is once daily. That's why it is increased the compliance. It has a mild side effects compared to other agents. We have a good, a wide variety of these medications. One of them can be used BID, like Risciola, but this is not convenient because it is less potent comparing to others. And now we have the Duresta, which is sustained release bimatoprost. It has a biodegradable implant that is injected into intracameral segment, and it is almost 1 millimeter in length, and it can be degraded and absorbed slowly for up to 3 months. It is approved by the FDA in the 2020s. And you can see it can be settled in the inferior angle without any complications. So prostaglandin in general had different receptor profile. We can switch between one agent to another, and we have a good outcome or a good reduction of the intraocular pressure. So the mechanism of action, as you all know, it reduces the pressure by enhancing the uvoscleral outflow. And this is going to be through the uvoscleral to the collector channels. There is questionable reports like in conventional outflow, but this is under studying. Nothing approved this. It has many contraindications like hyperactivity towards the preservatives. It is not recommended in contact lens wearer and in inflammatory glaucoma like uveitis. It's not recommended in acute angle closure glaucoma or any inflammatory process. It is recommended to be stopped before cataract surgery because it can induce CME. And it is not recommended to be used as the first agent if we can treat the one-eye patients. Because it's not acceptable cosmetically if we treat the one eye comparing if we treat both eye altogether. So side effects, one of them and well known is the hyperemia. It is more or more with travoprost and bimatoprost comparing to other agents. Foreign body sensation, itching, stinging, it's more of other drops as well. The well-known side effects of the prostaglandin, as you know, is the eyelash changes. So it's change in length, change in thickness and in course and count and pigmentations. It is reversible, fortunately, and the incidence in 14%. It is more with bimatoprost and travoprost compared to latanoprost. And the iris color changes. It is maybe from 30 to 40% in incidence rate. It is irreversible, unfortunately. Uniprostone or Risciola, it's not common to have iris color changes, Prostaglandin increase the melanin content, not the melanocytes numbers. So as you compare this patient, you can see the lashes and the pigmentations around the orbit. And of course, you can see the orbital fat around the eye is not as the other eye. Can you concentrate on the iris pigmentation as well? It is more dark and pigmented compared to the other eye. This is one of our patients, by the way, at KKISH. The other side effects is periocular fat atrophy and deepening of the sulcus, cystoid macular edema, and activation of herpes keratitis, anterior uveitis, and some reports mentioning dyspnea and acute asthma. It has to be used with caution in pregnant ladies because it can be very harmful to the fetus and to the pregnancy and induce early miscarriage. We have a new medications on the pipeline, like in the Vyzulta and Rocklatan and Ropressa. It is already in the market. We don't have it in the Middle East, by the way, only in the States. So Ropressa is nitarsodil ophthalmic preparations. It is approved in 2017. It is Rho kinase inhibitors, which is the first new class of glaucoma medications, and it is used once daily. Decrease the pressure by enhancing the trabecular outflow and decreasing the production of the fluid, and as well decreasing the episcleral venous pressure. Vyzulta, it is latanoprostone bonode, which is nitric oxide in addition to the latanoprost, approved in 2017. Again, it's once daily use. It has dual mechanism like trabecular outflow and episcleral outflow. Rocklatan is a combination between latanoprost and nitarsodil, approved in 2019. And one of the side effects of Rocklatan is hyperemia and pain, and corneal verticillata, which is not there of any glaucoma medications, and conjunctival hemorrhages. Fixed combinations, it is, in the markets, and which is more convenient to the patients. First of them is Cozopt, which is dorzolamide and timolol, and Azarga, which is a combination between brinzolamide and timolol. Combigan, it's a combination between brimonidine and timolol, and Simbrinza, which is the latest combination between the brimonidine and brinzolamide. And Gamfort is a combination between primatoprost and timolol. Dutraf between travoprost and timolol. Zalacom, which is approved in 2001, is a combination between latanoprost and timolol. And Tapticum, which is well-known, preservative-free, and lately approved between the tafloprost and timolol. We don't have it here at KKISH or maybe in the Kingdom. Rocklatan is a combination between Zalatan and Ropressa. So a fixed combination in general, it improves the adherence, very helpful to improve adherence and decreasing the cost if the patient can afford this medication from outside. It has a more IOP lowering effect if we compare this medication to other medications alone. It reduced the exposure of preservatives and improved the quality of life. We have a preservative-free preparations of glaucoma medications. It is very helpful in people who are already allergic to medications or preservatives. And the last category is osmotic agents. Osmotic agents is nothing new. It is old preparations back in the 1960s. It is used as a preoperative preparation for surgery. It can be used in acute or extreme elevation of IOP and in aqueous misdirection in some cases. The mechanism of action is increase the osmotic gradient between the blood and the ocular fluids. And the result is the movement of water from the eye to the circulation. And eventually this can reduce the volume of the vitreous and ultimately decrease the pressure. It is contraindicated in dehydration, acute pulmonary edema, contraindication in severe cardiac decompensation, renal or hepatic impairment, contraindicated in hypervolemia and electrolytes imbalance, and confused mental status. Oral glycerol is contraindicated in diabetic patients, especially in uncontrolled diabetic patients. These are the regular doses of glycerol and mannitol. It has a long list of side effects. And if we plan to give these medications preoperatively, it's better to let the patient go and empty his bladder before going to the surgery. Otherwise, you will stop your procedure many times on table. So let's conclude with this. We have to communicate well and build trust with the patients. And we have to pick the right medication, which can achieve the target intraocular pressure with minimum medications and convenient for the patients. And he has to be comfortable with them. So many medications we are prescribing to the patient is not good if we just minimize these medications. It's very depressing to the patient to use many medications. So we have, again, to consider other aspects like allergy, compliance, and if there is an assistant to the patient at home, we have to consider the cost if the patient afford these medications from outside. Again, we have to consider life expectancy of that patient and the stage of the disease, and also other comorbidities, and if the patient has an access to the health facility. Also, education is very important to give to the patient or to send the patient to the health education department. And we have to consider surgery if the patient is progressing despite using these medications properly, or if the patient is non-compliant to the medications, or if he is not responding well or allergic to the medications, or if he has no access to the health facility. And it's better to make sure before planning surgery to make sure that the potential benefit is outweighing the risk of the procedure. Thank you very much.